few slides.
Okay, so if you don't mind, can you check share screen?
Yeah, absolutely.
You might want to stop the recording because this all will go to the participants too.
No, we'll not share. Evelyn, abhi band kar do, babu, recording.
Can you see my screen? Is it visible there?
Yes, it is. Okay. So you face no problem. Yeah. We'll wait for 1 more minute. And by the time, let me also keep on welcoming the enthusiasts in the social norms platform. We'll just wait for 1 more minute. Okay, let me start. Otherwise, we will be stretched to the time, and I really don't want to stretch on the actual technical conversations with these experts here. And very good afternoon from India, and all the good day from wherever people are joining. And a very warm welcome to all of you on this platform of Social Norms Learning Collaborative. Social norms, social norms, social norms. We are really hearing it a lot across the globe. Everywhere, we are really talking about it when we think of sustainability, when we think of sustainable changes with the communities, whether it's human rights, climate change, economic empowerment, anything you say, that social norm is at the core of it. I think there is a realization that we need to be at the core to really solve the problems, and the problems are becoming more and more complex. I would say that, the problems that we were talking and discussing in the late 90s are still there. But if we are able to really review those notes, we would find that although the problems are still there, but the complexity of that problem have really evolved a lot. And to really unravel the problems, to really unravel the complexity, somewhere it is very important for us to understand the normative issues, whether it is due to the existence of the norms or whether it is due to the non-existence of the norms. So hence, I believe we all would agree that talking about social norms, understanding social norms, incorporating social norms into our entire consideration of working in the development sector to solve complex problems is very essential. So the social norms, the definition that we understand on this platform is that these are those informal rules, informal regulations that has been governing our beliefs and systems, that has been traditionally, culturally going on, coming down generation after generations as a social construct. Who does what, how, why? These are mostly unspoken and unwritten. These are all going from generations after generations down the line through as a perceptions. There is a carrot and stick mechanism there. There is a reference group who ensures that people are sticking to some of the power dynamic norms, their roles and everything. So existence of norms, non-existence of norms, everything has been really shaping up our lives and living, and maybe our lives beyond, when in the unborn and beyond death as well. So hence this platform welcomes all sort of discourses across to really talk about and understand social norms. And the vision of this platform as a social norm platform is to advance normative changes by encouraging our members to strengthen the conversations, build capacities, facilitate each other, learn from each other, that how social norms can be really studied and learned. We really welcome all sort of people across the spectrum of whether you are a researcher, whether you are a practitioner, whether you are an academician, whether you are just an enthusiast who are really interested in curiosity, who have a lot of experience, everybody to be a member of the platform. It's a free and open platform which actually believes in the richness of the technical discussion that is possible here. We want people to learn from each other so that the best of the investment goes in rather than reinventing the wheel everywhere. So without much losing the time, I would now head towards today's webinar. So any webinar has some housekeeping things. So I would request Anika to come in and a little bit talk about the housekeeping things for today.
Sure. Thank you, Sushmita. So before we begin the session, I would like to go through a few housekeeping rules that everyone can keep in mind. First, please keep yourself on mute and keep your videos off during the session. During the session, all questions are to be posted on the chat box, and we will be having a question answer round post the 3 sessions, wherein the panelists will try and answer as many questions as possible. And we will also try to answer the remaining questions in the chat box. So you can just enter your questions there. And if you want to ask anything or contribute to the discussion during the Q&A round, you can raise your hand and we will request you to unmute yourself and speak. That's it. Thank you. Back to you, Sushmita.
Thank you, Anika. And as you all may see, the chat window is open. Please feel free to provide your reflections, provide your questions to us. As we really believe in this, strong technical discourses, and would love to have your thing. And I must say this webinar is not the end in itself. It's just one of the milestones in our journey to really talk about that social norms is a topic that we all are eager to learn. So with respect to today's topic, as I was mentioning that, the problems are still the same, but the complexities have become much more complex. Today, we are going to talk about the human life stages, where we all know that, human rights and all those things, there is a choice, voice, we have been talking about. But today we have very intentionally kept that phase of life where you may not have a choice and voice. We are talking of infants, the children within the time period of first 1,000 days. We all know first 1,000 days is the golden period of human development. Children unborn, newborn of any age or sex, they all have the full potential of a physical and mental growth during this time. However, knowing all these things, we have also got to know that social norms are also existing in this phase. Social norms in this phase also guide, shape up our actions, reactions, our perceptions, our thinking, and that not only shape up the unborn, but also the newborn and everyone. So while there is a lot known about social norms, that how it impacts, it is also important for us to understand what to be done. We are not here to say that every social norm has a negative or a regressive impact. But there are some which are good, which are not so great, but that needs to be modified to the evolving timeline, to the evolving lifestyle that we really want to see for equal and equitable opportunities for all. What sort of design or interventions would work to influence social and gender norms? That is the question that I believe our speakers will be talking about. What is the measurement related learnings? How do we measure it? How do we see it? What are the indicators that really tell us the potential for learning and understanding the norms? So today is going to be a very interesting discussion, and we have a very experienced panel who has worked on these social norms to really talk about the survival, development, protection, and the participation rights of children in this age group. We have a very experienced and expert on the topic as moderator. So let me also introduce to all of you Yeva Avakyan. And you must have also noted, I think I missed it, that Social Norms Learning Collaborative is actually presenting this webinar in participation with Save the Children. And we are really glad for them to come up and co-create, really think about the entire webinar with the SNLC team. And so let me also welcome Yeva as our moderator. Eva leads the advancement of gender equality and social justice at Save the Children US. She is the leader on prevention and response to gender-based violence, advancement of gender equality and social justice in workplace across program and research initiatives. Eva brings over 2 decades of progressive leadership experience in social and international development with strong commitment to the advancement of equality and justice. This all includes design, management, research related to child, early and forced marriage, justice, community-based and multidisciplinary response to gender-based violence, social and gender norm change, prenatal sex selection, gender-based violence referral, information management system, and driving organizational change for gender equality and social justice. You all must have already assumed that I'm going to read multiple pages because yes, she is an expert in this domain. Without taking it further, I'm sorry, Eva, let me just stop here introducing yourself and would hand over this entire webinar to you and to your moderation. Over to you. Thank you.
Thank you. Thank you so much, Sushmita. It's always very awkward hearing that about yourself, but I appreciate it, and I'm so honored to be moderating this panel today. We have a very distinguished group of panelists who will be speaking on a range of really important issues related to social and gender norms and their impact on health and well-being of children. I think one of the things that we're here today to discuss is how social and gender norms can influence a child's growth and development from beginning, even from prenatal stage. As we begin our discussion, it's important to recognize that social norms are the unwritten rules about how we should act around each other. They're informal, they're often implicit rules that most people accept and abide by. They're shaped by what we expect from each other, right, in our social groups. And they come from things like, what we observe other people doing or what we think other people think that we should do. As many of you know, the first 1,000 days of a child's life are crucial for the overall growth and development. And during this period, social and gender norms play a very significant role in shaping a child's life and development. We do know that these norms and gender norms, which is a subset of social norms, those norms that do not exist in a vacuum. They influenced by a range of factors in the social ecological framework, from individual interactions, families, community, towards more of a macro legal environment. And so that has been very important view for us to take as we look at addressing social and gender norms. And like Sushmita said, not all norms are bad, not all norms are harmful to everyone. And they're very contextual, and they're very sticky. They don't change very fast. And so some of the things that we have learned at Save the Children from in our work in addressing social and gender norms, particularly in childhood, we have learned that they have an enormous impact on the trajectory of child's life. That's something that we know, and it's gender inequality starts in childhood, starts even before the child is born, and so the work that we've been doing around parenting, around intersection of even violence against women and violence against children has been really important in creating an environment for children to thrive and grow and develop. So parenting, positive parenting interventions have been incredibly important. Positive fatherhood and male engagement has been something that we've really made a huge progress on, and you will hear more about this work from other panelists later today. Things around education, and both in education in terms of on the level of the sort of family, community, and the macro policies, etc., which has been really important. Addressing, girls' empowerment, and what does that mean to this distribution of power in the household and society, how we look at who has power and how that power is practiced. And finally, really important, the role of media, and something that you will hear as well in the conversation today is the role of media in shaping and changing social norms. So today we will delve into how child, family, community, and broader societal factors interact and influence social norms related to health, nutrition, and development. And our panelists will be exploring some of these issues in depth, offering insights on how we can work to shift some of these norms to improve health and well-being. So without further ado, I know you have an amazing group of panelists who are keen to share with you some of their insights in the work. I would like to introduce our first speaker, Dr. Antaryami Dash, who is the Deputy Director of Health and Nutrition at Save the Children. And Dr. Dash is a public health and nutrition enthusiast. He is currently heading the health and nutrition section at Save the Children India as a Deputy Director. He's had over 15 years of experience in program management, designing programs, harvesting its outcomes to influence policies. He provides thought leadership, technical guidance, and knowledge management support to strengthen program and delivery at scale. Over to you, Dr. Dash.
Thank you, Eva, for the generous introduction. Let me share my screen. Is it visible?
Yeah.
So thank you for
we can see your screen.
Yeah, thank you for giving me this opportunity. This is a very interesting, context, where we will be talking about the social norms, and you already mentioned that the gender norms are a subset of the social norms and how they are affecting infant and young child feeding practices in India, especially the breastfeeding practices. This is the topic. By the way, this is an unpublished paper, but this is based on our groundwork and primary data that we collected. So I'll be taking you through some of the data points and the learnings that we achieved from this project. So my colleague Indrajit, Bhavita, they all helped me doing this. So all of you know that optimal breastfeeding practices, if can be provided optimally, it will save 820,000 child's life in a year and 20,000 mothers' life in a year. But unfortunately, that practice is normal. If you look at the global level, the exclusive breastfeeding is just at 42%, and the SDG target is to have it at a 50% level. So there is a faltering of adequate and optimal breastfeeding practices across different countries. One of the reasons why it is difficult to achieve an optimal level of breastfeeding practice is mere numbers and different times, and how many times you have to pursue this for a long time. If you have to look at the first 2 years of a child's life, there are around 5,000 feeding moments from birth to 2 years, And this is, I'm including complementary feeding as well. How many times the mother has to reinforce and remember and follow the best practices is a matter of chance. If the mother is not imbibed or influenced or capacitated to follow that practice for a long time. That's why I say, such kind of things which require a very recurrent and a long-term home-based and a nuanced nature of practices, that becomes very challenging than any other service-dependent behavior. So, for example, full immunization. It is a one-time event that will happen in a center and you are done. But this is something you have to do 8 times a day for 2 years, and that's not easy. Literature says that mothers are 2.5 times more likely to breastfeed their children when their breastfeeding is supported, promoted, and protected by the family member and the community member. There are enough literature that support that mother's decision to breastfeed is also associated with cultural, social, personal, and environmental factor that includes all these norms that we're talking. And they see that their spouses play a major role in influencing their decision to breastfeed. And many times it turns to a positive atmosphere when the husband plays that role in the household level. So our study that I'm proposing is to understanding the attitude and involvement of young fathers on specifically the breastfeeding issues. This is something that we did through both online and offline, because some of the data is collected immediately after the COVID-19 pandemic. That time we couldn't meet them in person, so most of it happened through telephonic. But after that, we had an offline direct contact with those young fathers, and it was done through a CAPI-based, mobile-based question. So the targeting was young fathers who had at least a child between 6 months to 24 months, so that this IYCF questions can be asked. And in case there are multiple children in the same household, then the youngest child was taken as the youngest child, and it was a multi-state convenience sampling. Here attitude implies, and that it's a very complex phenomena that encompass both cognitive knowledge, thoughts, and affective feelings and behavioral components. That's why the tool is designed accordingly, and involvement is very straightforward. It is both emotional, practical, and physical involvement of the father on breastfeeding practices. I will take you to the tool as well. So in nutshell, out of the 473 samples that we achieved from urban, it was 14. The rest was mostly rural India. From these 4 states, Uttar Pradesh, Rajasthan, Delhi, and Jharkhand. And you can see the education level of both father and mother. So, yeah. So if you look at the practices that is happening, exclusive breastfeeding in this cohort of households, exclusive breastfeeding is happening for 50% of cases, and continuation of breastfeeding is happening for 1 year is 47%, and continued breastfeeding for 2 years, that is a recommended practice by WHO, that is happening at a very minimal level of 12%. Now, to check the internal consistency of our tool on attitude and involvement, we did some tests in the pilot testing with a small sample size. So, for example, in attitude, there are 13 questions, and each question has a 5-point Likert scale. And we tested the internal consistency, and we found that the Cronbach's alpha, or the consistency level is very decent to go ahead and do the final data collection. Same thing with involvement. There were 11 questions at a 5-point Likert scale, and the internal consistency was okay to go with that. So these are the attitude level, questions, 13 questions, and you can see, some of the questions, they got a, good mean score, and there are some questions that has a very minimal, mean score. But this is all about their knowledge, awareness, understanding, and attitude towards breastfeeding. We can come back to it if you have any specific questions. Same thing around involvement, and these are emotional, physical, and practical engagement of father on the breastfeeding issues of their child. And you can see the mean score varies between different indicators. And there are some, where the mean score is very good. Say, for example, allowed your baby to sleep in the same room without any objections. So majority of the fathers have agreed to that, and they have allowed the baby to sleep in the same room. So this is a practical, support, right? So discuss with your wife on the benefits that breastfeeding has for her baby, for her and her baby. So there are some indicators you will find there is a good score. There are some indicators you will find lesser score, but we will come to that in detail. So overall, attitude leads to involvement. That is also proven from the data that if there is a strong positive association between the level of attitude versus involvement. So in our program, we should first focus on building the attitude, and involvement will follow gradually. So father's involvement increases with increasing age of the child. That's also very interesting data we find. But attitude remains the same. This is the attitude, the mean attitude level across different age group. It remains same. But father's involvement is increasing with increasing age of the child. And we asked further questions. There are apprehension. There are fewer factors. Some of the young fathers they apprehend to handle and carry the small baby or the infant, but their engagement and their connections improve as the toddler become little older. So that's how the total time spent by the father increases with age. So this gives us another programmatic input how we should orient and capacitate fathers to handle the young infants as well. So this is interesting. The level of attitude is defining the continuation of breastfeeding and exclusive breastfeeding in different groups. You can see if the attitude is more, you will see there is exclusive breastfeeding is happening, and continuation of breastfeeding for a year, continuation of breastfeeding for 2 years is happening. All these things is positive if there is an attitude. But if there is an involvement, all these things are happening, even at a higher level, even at a much higher level than just attitude. So involvement is also reinforcing that if fathers are engaged and involved with attitude, then all these best practices can be ensured in this sample. So my last few points in conclusion, I would like to make that infant and young child feeding is very much a product of the social norm, including the gender norm and the patriarchy, and the kind of typical role fathers in this modern society have presumed that this is a kind of duty. Is it my duty or is it the spouse's duty? So it's all very complex, and we need to understand that complexity. Mothers, many a times they follow their peers and what is being practiced in the community. That is something we call as a descriptive norm. If majority are not following exclusive breastfeeding, if their friends in social media are talking something which is not a recommended practice, then many a times mothers might influence through that. There is a study by Save the Children in an emergency setting. It shows that distribution of infant formula in the community has a very trickle down effect, and 42% it can minimize your exclusive breastfeeding rate. It can dilute exclusive breastfeeding rate because of the descriptive norms a mother might learn from other, without understanding that that mother has a specific need to have a formula, but that doesn't get translated, and there is a peer influence. It affects all of them negatively. Feeding practices are also influenced because mothers believe that those who matter to them, they should approve of her practicing to a particular behavior. This is that we call as an injunctive norm. And in our case in India, many mothers they give extra importance to husband, to mother-in-law and other people in the household to approve certain things, because they follow this kind of norm. Unless they approve, they think it is not correct to practice. So these are also there in every society, I guess. Now this is very important, something called a pluralistic ignorance. Sometimes mothers and even fathers, they incorrectly assume that the majority are conforming or expecting them to do so. But in reality, it is not the case. The example is, say, for example, there are many TV ads or giving water to the child less than 6 months during summer. Many mothers will give that, but in practicality, they will not get an approval if you talk to them, one-to-one. But they mistakenly assume that this is the approval from the community. That's why they will do it. Janam Guti or grind mixture. These are very commonly practiced in India. Even prelactal feed. These are a classic example of pluralistic ignorance mothers are undergoing. So how should we handle this? The social norms can be, as you said, Susmita, in the beginning, they can be beneficial and they can be harmful as well. So the things that we can do at a programmatic level, we should do a normative assessment and provide an appropriate behavioral nudge, that target the entire ecosystem, not only the individual mother, but the entire ecosystem through a very targeted behavioral interventions, and I call it ABCD, that is understanding their attention, belief, choice, and determination on a particular issue. And in our case, to help them practice IYCF optimally. So this is something I thought I should be sharing with the group. If you have any questions, I'll be happy. Thank you.
Thank you very much, and very interesting. I love the ABCD, very easy to remember: attention, belief, choice, and determination, that go beyond just parents, but also care providers and the trying to reach the whole ecosystem. Thank you. That's really great. I'm going to pass over to Dr. Amrita Misra, who is the Deputy Director for Health and Nutrition at PCI India. Dr. Misra is an MD in community medicine. She received that from Lady Hardinge Medical College and has over 22 years of experience in managing projects on maternal, newborn, child, and adolescent health and nutrition, WASH, infectious diseases. Before joining PCI India, Amrita worked with John Snow India as Senior Technical Advisor, and she's a member of the Technical Advisory Group on kangaroo mother care and several other professional and advisory bodies. I told you you're here for a treat. We have an amazing panel, and Dr. Misra, over to you to speak about myths and misconception about complementary feeding practices, about role of men and husbands, self-groups, as well as how norms change to program design. Over to you.
Thank you so much, Eva. That was an interesting introduction. I hope I can live up to everything that you've said. So I'm going to be sharing the findings of a very interesting ethnographic study that has been done by PCI and the organization called Vihara in Bihar in a couple of geographies. And why I chose to present this is because it provides very incisive insights into very actionable points that can be addressed by all of us to change social norms. And what are those social norms that actually affect complementary feeding? As Karyami said in the earlier presentation, social norms play an extremely important role in all nutrition practices, not only breastfeeding, but also complementary feeding, and also later on in life, how we treat our adolescents, what we feed our elderly, all of those, for all of those social norms are extremely important. So I'll just talk a little bit about this study. So this study was done in villages of Bihar. A large number of groups were connected with them. These are various patterns of families were interviewed for this study. The two districts were Samastipur and Nalanda, and these are some very remote districts of Bihar. And these were the research methodology: home ethnography, family tree, and role allocation, grow, buy, don't eat, and mothers interviews. Coming to the findings from this entire experience of ethnographic study, what they found was that these are the 6 main kind of factors that determine the uptake of complementary feeding in these societies. As we know, complementary feeding in India is low, meaning the timeliness is not as good as it should be, and diet diversity, diet adequacy is extremely low at 9% in the country. So what are these factors? Familial support emerged as one of the key factors for initiating complementary feeding at the right time and including the diet diversity. So I think most of the audience would be informed that for diet diversity of children for complementary feeding, out of 7 food groups, at least 4 should be consumed on a daily basis, which we say is diet diversity. Familial support, access to trusted channels of information, women's agency, adherence to socio-cultural norms, mental models around the need to feed, and stakeholder aspirations. These are some of the factors that emerge very prominently that affect the uptake of complementary feeding. Further, these are some actionable things that can be done, what we can do in the field to change these norms if they need changing. So there are 6 of these, but I'll focus on these 4 because they're more relevant to this particular presentation, especially when I am basically going to integrate this with the SHG platform. The self-help group platform is what PCI works closely with, and these 4 factors are what we can really impact when we work with the self-help group platforms. So opportunity area 1, how can we really change the complementary feeding uptake? So advice converts to practice when it comes from a trusted source. This was the first finding and really integrates with, relates to social norms. Who are these trusted sources? Generally, this is the family. These are the medical practitioners. This is the woman's agency herself. What we found is that, just this strip, I don't know if you can see this.
Yeah, it's all good. You can continue.
This thing is not showing up in my screen. Anyway, so I'll continue. So in practice, in families that had very good practices, mothers received very active emotional support from their families, particularly from their natal homes. And with access to mobile phones, everyone is connected to their natal homes, and the mothers of the mother came. They seem to be the most important and trusted source of information. We've always known that the role of gatekeepers, like the mother-in-laws, are very important for any nutrition action for children. But here we found that mothers of the mother has become a very important trusted source of information. In non-adopter families, the women had very low mobility and agency and are restricted from visiting their natal homes. The other opportunity area is the entire family relationship, the familial support, the women's agency at home, access to trusted channels of information. So the family members, if they supported the mother and had loving relationships, listened to the mother, they had better access to complementary feeding, and their complementary feeding practices were better. The father's role here was quite important. The other members of the family's role was quite important. The families that did not receive support from their other family, the mothers did not receive support from other family members, the uptake of complementary feeding was poor. The third opportunity area is that girls growing up with agency are able to establish their position in marital homes and build supportive relationships. With agency basically means that girls who have, these were women who had some amount of literacy, they were brought up with a lot of love and affection, they were trusted by their families, emotionally supported by their families, They had better negotiation skills within the family and in their marital homes. So they were able to uh, ask and seek for the right kind of foods for their child and gain mobility to get or procure these foods from the market, or at least ask someone to get these foods from the market and adopt better practices. Another important aspect, particularly when we are talking about self-help groups, is that when caregivers are involved in local agriculture, livestock, or ecology, the child diversity, diet diversity is higher. In rural communities, we found that those caregivers who are involved in farming were able to actually give better child diet diversity. Even in some neighborhoods of landless farming, where the landless farmers were growing edible plants, etc., in nutrition gardens. So makes the role of a nutrition garden or homestead garden very, very important. The households that did not have access to these farm products or were very large landowning families and had given the land to somebody else to grow food did not access the food from their own land, and therefore their family diversity was low, which is very counterintuitive. So overall, if we look at these various factors, familial support, trusted channel of information, women's agency, mental models, adherence to social cultural norms, and stakeholder aspirations, all of these played a role. And if we look at this particular table, messaging, the right kind of messaging played a very, very important role. So what are the kind of messaging that we can address for uptake of better complementary feeding? So encourage families to temporarily adopt flexibility in role allocation. So basically, if childcare becomes the responsibility of the whole family and not just of the mother, the overall care of the child will be much better. That really brings us to the point that as a health professional, many of us as doctors or as public health specialists, we target families with information only regarding that particular aspect. For example, yes, consume 4 food groups out of 7. But we don't address these other factors that are going to influence the uptake of those 4 food groups. So if we are able to address the surrounding factors, the ecology around that mother, then the kind of nutritional outcomes will be much better. Second thing is that leverage continuing influence of natal mothers on young mothers. So if there is a dependence on the mother for information, the mother also needs to be empowered with the right kind of information. Here in this slide, we are referring to Jivika. Jivika is the self-help group body of Bihar, and the self-help groups under PCI's interventions, the self-help groups have been mobilized to influence social norms. And in later slides, I'll explain what difference it has made in the community. Another important aspect is peer group support, which has not emerged in the earlier slide. So it's not just the family, but it's also the peer group that can have a very strong impact on complementary feeding uptake. Women's agency, as I said, self-help groups, because we're talking about self-help groups here particularly, there is a factor of women's agency in how self-help groups and financial empowerment, financial freedom can improve women's agency within and outside the family. Mental models, these are the kind of the way that a woman thinks, her dependence on various influencers who are going to change her mental makeup on how to bring up a child. Adherence to socio-cultural norms, we've already discussed, and stakeholder aspirations, what they want to exactly achieve. And this in fact is becoming a more and more important aspect, where even in rural areas, families are turning to junk food and taking fast foods, giving children fast food as an aspiration, and as just blindly adopting what they see in urban areas and what is considered fashionable. So this is something we will have to soon start addressing. In fact, a lot of us have already started addressing this issue. So this is a very busy slide. I'll not get into it much, but basically PCI has a 10-year program in Bihar under which we have engaged with women of self-help groups to mobilize them, to reach them, engage them in various maternal and child nutrition practices. And if you can see on this slide, we have been able to achieve significant difference, significant improvement in diet diversity. It is almost double of what it used to be in the intervention blocks. From a 12.8 minimum diet diversity, we have been able to achieve a 26% diet diversity, which is as good as the best in the country at the moment. The best in the country being Goa and West Bengal at 22 and 23. So Bihar in the intervention blocks has been able to achieve the best dietary diversity for children through the Jivika interventions. Thank you very much. If there are any questions, I'll be happy to address.
Thank you very much, Amrita, and thank you for really demonstrating the complexity of this work and how many touch points need to be addressed in order to really significantly improve health and nutrition outcomes in this work. So thank you very much. And last but not least, we have Mr. Ankur Garg, who currently serves as BBC Media Action's Country Director. And he holds MPhil in Technology Policy from the University of Cambridge, where he was a Chevening and Commonwealth Fellow. At BBC Media Action, he's been a key driver for innovative communications agenda, including helping bring Clean India mission onto international agenda, supporting the thinking about impact investments for communication interventions, creating organization's first climate mitigations action portfolio in Indonesia, including creating media market shifts on the subject, and bringing machine learning to strengthen our immersion and segmentation approaches for digital communication strategies. Ankur, take it over to you.
Great, thank you very much, Eva. As you said, it's very awkward to hear about yourself in a panel, but thank you for that introduction. I hope you can all see my screen properly. If you can't, please shout.
Yeah, it's okay.
Great, thank you very much. So what I'm going to talk about today is Kilkari, which is an intervention that BBC Media Action co-created in partnership with various organizations and partners back in the day, focusing on maternal and child health, and a subset of the critical 1,000-day window that we've been talking about. So I'll take you through the story of Kilkari and various choices that we've made along the way, which are aligned with norms. So starting with Hello Bhaiya Bhabhi, which is brother and sister-in-law, which is starting with the positioning of the service as something that was to the couple and not to an individual. And I'll go into the reasons for that, which align with our own research study on that. So for those of you who haven't heard about Kilkari earlier, it's a mobile health education service that provides pregnant women, new mothers, and their families with timely, accessible, accurate, and relevant information about pregnancy, childbirth, and childcare. It covers the 72-week window from the second trimester of pregnancy till the baby is a year old. And the service makes an outbound call with pre-recorded audio content directly to the subscriber's mobile phone, which is then time-appropriate information. Kilkari sits with two other mobile health services. So sat with two other mobile health services when it was designed. It was designed originally for health workers and households in Bihar using interactive voice response, or IVR, as the appropriate technology of choice. The complementary suite of mHealth services are based on a single theory of change, which was based on the premise of providing timely, accessible, accurate, and relevant information that improves knowledge. However, while knowledge is necessary, it isn't sufficient to change anyone's behavior. And therefore, what we've heard from Dr. Dash earlier around negotiations between sort of parts of the ecosystem, such as the frontline health workers and families, becomes critical to improving the self-efficacy of families themselves. Discussion, including interspousal discussion and communication, is often a very key and strong gateway to change. And increased knowledge and better interpersonal communication skills will make frontline health workers more confident and motivated in performing their job. So there were three parts to the puzzle. The first was Mobile Academy, a training course for frontline health workers, which was aimed to refresh their knowledge and improve their communication skills. The second was a job aid, again aimed at the frontline health worker, called Mobile Kunji, which equipped them with the job aid to be used during the counseling sessions. And Kilkari, as a direct-to-consumer service, sought to improve the family's knowledge of healthy RMNCH practices, addressing both wives and husbands and reinforcing information communicated through the frontline health workers. So in 2013, from Bihar, the Kilkari and sort of the mHealth services got scaled up, got the approval to be scaled up through the National Health Mission in India. And then in 2014, the National sort of Ministry of Health and Family Welfare asked the Gates Foundation and BBC Media Action to support in scaling these three services. However, just before the launch, it was decided that the two services that would be scaled up were Mobile Academy, which was the training program for frontline health workers, and Kilkari, the direct-to-consumer service, and not Mobile Kunji, the job aid. So while this left a significant gap in our ingoing theory of change, the two services still selected, the digital services selected for scale, were complementary, both in terms of sort of building the ecosystem as well as building knowledge and awareness and shifting those norms with the beneficiaries. So in 2016, the government launched these services, and 3 years later, 2019, Kilkari was the world's largest maternal health messaging platform. So in addition to scale, one of our key goals was to transition the service and the sort of the entire property to the government. So MOFHW, which is the Ministry of Health and Family Welfare, was supposed to take the 100% responsibility for the services in 2019. But eventually, the model that we have right now is a local NGO organization called Arman, supported by local and international philanthropy, supporting the Ministry of Health in sort of running the services. And we spent a year transferring all our knowledge, our assets, on every aspect of the service to Ministry of Health and Family Welfare, as well as to Arman. And in April 2019, we handed Kilkari and Mobile Academy over. When I'll go to the scale statistics later. But just to say that when we are talking about so while Kilkari as a service focused on that 72-week window, the other mHealth services, both Mobile Academy as well as Mobile Kunji, focused on the entire 1,000-day window that we're talking about. And a subset of those sort of intervention areas on maternal health, family planning, as you can see on the slide, was covered in Kilkari, which were basically time-appropriate pregnancy as well as child birth and childcare messages from the perspective of the beneficiary. So in designing this service, it's a tricky business, right? So content design is a tricky business. It's a balance of science and art and craft, as we define it as at BBC Media Action. And this is where the understanding of social norms, as well as integrating of those normative beliefs, played a critical part in terms of both how we design the service as well as how we rolled it out. So I'll give you a couple of examples. The first is, as I said earlier, engaging both mothers and fathers, because we knew that women were likely to share the husband's mobile phone and had low or no decision-making in many cases over their own or their child's health. And therefore, it was imperative to design the content that engaged fathers as much as mothers. And as Dr. Dash said earlier, that there was also a component of lack of interpersonal